Hi, I am Senior Clerk Noli Gapia and I will be demonstrating tracheostomy tube insertion. The procedure refers to the creation of a communication between the trachea and the overlying skin. It is used for airway obstruction, respiratory support, pulmonary hygiene, elimination of dead space, and treatment of obstructive sleep apnea. Pre-operatively, the surgeon must be aware of the anatomy of the neck. He should anticipate difficult tracheostomy in patients with short necks, thick necks, and necks that cannot be extended due to different conditions. Coagulopathy should be corrected prior to surgery. If not corrected, then have electrocoagulation available to aid hemostasis. Cardiorespiratory status of the patient should be assessed as several conditions might endanger the patient's life with tracheostomy. A chest X-ray will alert the surgeon to tracheal deviation due to cervical and mediastinal tumors, or traction on the trachea due to fibrosis. And lastly, if airway obstruction is because of laryngeal cancer, then one should attempt not to enter the tumor during tracheostomy. This may require a lower tracheostomy if tumor involves the cervical trachea. The materials needed are cotton with iodine, retractors, suture set, tracheostomy tube, suction, scalpel, and retractors. The procedure. Patient may cough upon insertion of the tube, so eye protection is recommended to prevent transmission of infections such as HIV and hepatitis. Unless the patient can be safely intubated or the patient can be ventilated with a mask, a tracheostomy should be done under local anesthesia. If there is concern about the anesthetist's ability to maintain an airway, then the surgeon should be present during induction. The skin, soft tissue, and trachea should be infiltrated with local anesthesia with adrenaline before induction, and a set of tracheostomy instruments should be set out before induction of the anesthesia so that an emergency tracheostomy can be done if required. Positioning and draping. Place the patient in a supine position with the neck extended by a pillow or bag placed under the shoulder to deliver the trachea out of the thorax and to give adequate access to cervical trachea. Sterilize the skin of the anterior neck and chest and drape the neck. Surface landmarks. The tracheostomy is created below the first tracheal ring to avoid subglottic stenosis as a result of scarring. Run the finger up the midline of the neck, starting inferiorly at the sternal notch. The first prominence encountered is the thyroid isthmus, followed by the cricoid. Alternatively, identify the thyroid prominence or the Adam's apple, moving inferiorly with the fingertips into the depression of the cricothyroid membrane, followed by the solid prominence of the cricoid cartilage. Incision. Make a horizontal incision, one finger rests below the cricoid prominence. It is cosmetically preferable to a vertical midline incision. Extend the incision through the skin and subcutaneous tissue. Take care not to transect the anterior jugular veins, which are just superficial to the strap muscles within the investing cervical fascia. They can be preserved and retracted laterally. Dissect towards the trachea by parting the tissues with scissors, remaining strictly in the midline in a vertical plane to avoid injury to the inferior thyroid veins. Identify the midline cervical fascial plane between the sternohyoid muscles. Divide the intermuscular plane by spreading with a pair of scissors. Repeat this maneuver to separate the sternothyroid muscles and retract the muscles laterally. The trachea and the cricoid can now be palpated. The thyroid isthmus overlies the second or third tracheal rings. Retract the isthmus superiorly with leg and back retractors to expose the trachea. Only very rarely does the thyroid isthmus need to be doubly clamped, divided, and ligated, or if small, divided with electrocautery. Expose the infrathyroid trachea by careful parting the overlying soft tissues with a pair of scissors, taking care not to tear the inferior thyroid veins. Ensure that the cervical field is completely dry before proceeding, as it is difficult to achieve hemostasis once the tracheostomy tube has been inserted. A silk traction suture is passed through the anterior tracheal flap and loosely secured to the skin. Insert the introducer into the tracheostomy tube. Ensure that the tube has been inserted into the tracheal lumen and not into a false passage in the paratracheal soft tissues. Intra-procedural complications of tracheostomy are airway fire, bleeding, and pneumothorax or pneumomediastinum, while early complications are infection, tube obstruction, and accidental decannulation. And lastly, the late complications of tracheostomy are tracheal stenosis, tracheoinnominate fistula, tracheoesophageal fistula, and tracheocutaneous fistula. Thank you for watching.